Hello and welcome to this absolutely fascinating interview with Hazem Fallouh. My name's Joel Dunning and I'm absolutely delighted to meet you, Hazem. Now, the reason we're here is because you are the winner of the Techno College Innovation Award this year in 2021. And I think you wiped the floor. You are absolutely amazing. And this is a truly novel but relevant device to all surgeons who do any type of cardiac surgery. So firstly, maybe if you want to tell us a little bit about yourself and where you work, and then we'll dive straight into this discussion of this amazing device.
Right. Well, thanks, Joe, for this generous presentation. I am actually truly honored winning this prize, but equally honored by the simple fact that I am being interviewed by a giant myself. I mean, you've led the way onto treating this difficult condition, which I will be touching on quite extensively throughout the 5-10 minutes talks that I'll go through. This is just a little addition to what is, sort of the protocol into resuscitation that you developed and Cal's to try to tackle this problem of cardiac tamponade. So I'm a thoracic surgeon. That's a disclosure, having been trained in cardiothoracic surgery, and I think I'm not unique that way. But yet I kept my fingers in some innovations. I've always liked the idea of solving problems, and through my PhD, I've learned the art of, so to speak, developing ideas, and we've got cardioplegia going through clinical trials shortly. And this is a problem that I think has been bugging me for quite some time as a junior trainee onward. So, and we thought we might work a solution out of it, and that's the product of some little thinking, but just a will to solve that problem.
Yeah, I mean, it's an amazing idea, a device to actually detect the pressure inside the pericardium to detect a tamponade. Exactly as you say, the STS in 2017 have produced guidelines that I had the privilege of chairing, basically saying what a massive problem tamponade is after cardiac surgery. 1% of patients arrest after cardiac surgery, and 30% or more of those arrests are due to tamponade. So what an incredible idea to actually have a pressure monitor in the pericardium to try and maybe avoid completely that. So maybe if you could tell us a bit about this device and where we're at.
Right. So PREDICT is, as the acronym kind of suggests, pericardial device to monitor cardiac output and diagnose tamponade after cardiac surgery. And it's gone through the Lions Den process of the Techno College Innovation Award, which was quite exciting and a bit nerve-wracking. But here we go. I think we'll start with a little case, vignettes, if you like, which kind of tend to bring the message home to people who might wonder what this is all about. Just happened to be a patient is still vivid in my mind from the days when I had cardiac surgery, who's had that problem. 73-year-old, if you like, a rheumatic valve ejection fraction of 40%, not a great ventricle to start off with. Quite an ambitious attempt by then my trainer, mitral surgeon, who to do the mitral rheumatic, which was aborted pretty quickly, and we put a magnet ease and throw in a bit of AF ablation. They tend to be a bit coagulopathic. Within a couple of hours, we dumped in a couple of 100 mils of blood. Nothing that some product could deal with, but the usual situation. At 11 o'clock at night, things started looking a little problematic with dropping blood pressures and inotropes requirement, and squeezing a couple of gela here and saline there, and patients becoming a bit positive. You're at the end of the phone in your comfy bed with the resident calling every half an hour with sets and numbers, which with the impossible task trying to get a picture of it. You got the gist. And then you've got a situation where the intensivists say it's tamponade, and the trainees say no, it isn't, because the drainage has not blocked. And you decide 3 a.m. in the morning to take the patient to theatre to explore the chest, and you would find some clots, and you take them out. The patient gets better. Intensivist is very happy. You got it right. You listen to him. It's all great. Patient out of ITU within 2 hours. But unfortunately, it's not always like that, is it? There's a parallel universe where it's the same surgeon, the same team, even the same patient. Circumstances can be different. You open the chest and there's not much of a clots. The heart is struggling, being the heart is not very good in terms of systolic function prior. And you decide to put a balloon. You dragged everyone out of bed in the middle of the night, and you're pretty knackered. You can't do the next day mitral valve. It's all right. The patient got the best treatment possible, but it gets even more complicated into the third universe, where you've already done a couple of the second one scenarios and decided you've been doing a lot of complex cases and you've been opening a lot of patients. You would want a TOE this time. And while you're waiting for your TOE and the anitas to come out, you get a call at 4 a.m. in the morning, the patient arrests, and your trainees open the chest, and you just need to calm down. And this is basically the two problems that we're trying to tease out and try to avoid with this device. Predict is a simple device that is the only one that is made to diagnose tamponade and monitor cardiac output at the same time. I think we've demonstrated enough that despite how safe cardiac surgery is, I guess you recognize these hands, Joel, tamponade remains a problem, and the challenge is always trying to make that diagnosis. And because it looks like any other heart failure, so the juniors in the middle of the night trying to make the call whether to take the patient back to theatre, looking at that, and often they miss it and you've got a cardiac arrest. And this is footage from the CALS course training model, demonstrating how you could try to get the chest opened in the middle of intensive care unit, because that's the best chance you could give the patient. And we all agree that it's the better way of doing it is, if you think you've got tamponade, do it while the patient has not arrested, take them to theatre and sort it out. So Predict is trying to sort this out by having, it's a simple device with a balloon and a Doppler probe. The balloon is not only to measure the pressure, but actually challenge the pericardial space, because you find the pressure is not very reliable. The Doppler probe, you sit it on the pulmonary artery bifurcation, it could measure cardiac output as well. And when you challenge the pericardial space, you'll be able to determine that. And it also could replace other cardiac output monitoring device at no extra cost. So at 1.5 million cardiac cases a year, an estimate based on the figures you mentioned is that's what we're looking at in terms of mortality and cost. So it's quite a big problem, and I think that's the, okay, just go back. I wanted to show you that little diagram here of some animal studies we've done to try to prove the concept in a pig's model. This is in collaboration with two clever cardiologists. One of them you might know, Joel, is David Adlam, who's come up with also a clever idea of a VAD that he put through the skin into the pericardial space, and then it just basically that fixes it against the sternum, and the other one is pumps in and out. And in collaboration with another clever cardiologist, Dr. Rodman, Alex Rodman, who's done a lot of work on devices on the pulmonary artery. So the idea is took the same concept that the balloon itself that you fix the device to looks exactly like what a clot would look behind the sternum. And if you blow it here to the first arrow, you see like a little dip in the cardiac output. You don't know what's causing it, but when you add your diagnostic balloon, which would be the device, the cardiac output, you kind of extenuate this thing, but at least you reverse it. So you'll be looking at a trend of what sort of volume will give you that cardiac output, and then you realize, you know how fast you're heading towards your critical cardiac arrest. So that's the proof of concept study in animal. So I think basically that's the concept in principle. Pretty simple, nothing too complicated. The Doppler itself, placing it on the bifurcation with an arm-fast view, should give you a nice flow of into the pulmonary artery, which is some data suggests that's likely to be affected first in the tamponade model. And I think is then their next step is trying to size the problem to see what sort of cost you're looking at, and say cost saving in terms of and life saving for that matter. We all know it's a problem, but people who's going to try to make a device like this, they want to know the size of it, and it's not good enough to say, I'm telling you, it's a nightmare. So, and then your challenge is trying to estimate what tamponade, the problem of tamponade, and the literature is not very clear on this. And I think this is a paper, again, I owe it to you, John, Joel, when that last, I think it was the last flight for me before the pandemic, crossing the Atlantic to the STS 2 years ago, where you told me about it. And it's quite an interesting one, showing the rate of cardiac arrest, which is, you mentioned 1% in the introduction, but I think this is a pretty impressive series from the Virgin Cardiac Surgery Quality Initiative, which is a pretty powerful one, as you know. And they looked at 17 hospitals and their VA consortium. And the first interesting findings and the variation in the rate of cardiac arrest based on the center, between 8% and 3.5%. So you've got already 5% variation, or more than double. And the next interesting one is the variation in mortality, or the failure to FTR, failure to recover, I think is the term, is basically who could survive cardiac arrest. And then you'd find that with that 20%, you're looking quite a bit of variation between one center and another. And it's bigger than we thought. And when you talk to surgeons from all around the world, the variation is the problem. We know in the UK, I guess it's pretty centralized. We know 2% mortality in cardiac surgery, not much. But then when you start going to centers that might vary in the number of cases they do and experience, things could become quite variable. And this is basically what the authors of this paper have concluded, that we should look at centers with the lowest rate of FTR and try to establish what they're doing right in some more research, but they put a lot of it on training staff in ITU to spot these patients. And you know a little bit about that yourself, or quite a bit about that, Joel, with your work on CALS, obviously. But the most important thing is, I think, is we really need to try to spot these guys before they arrest, because that's where the gain is.
Just winding back a tiny bit, just to talk about your probe a little bit more. You've basically got a Doppler probe on the PA that's measuring continuous cardiac output monitoring, is that right? And then the balloon is measuring the intrapericardial pressure. So you've got two readings on a continuous monitor, is that right?
So the pressure itself is one parameter you could do, but we found the best accurate way to determine the development of tamponade is the trend. And we felt that when we were doing some sort of preliminary proof of concept studies, challenging the pericardium is likely to give you the best result. So you inflate 10, you finish the case because you need your baseline. So when you finish your case, you put your chest drain, which these could be attached to it. You put your Doppler probe, you get your readings, you get your balloon, you shut the chest, you look at your baseline, and you blow in 20 mils in that balloon until you get a drop in flow of about 5 to 10%. And then you deflate the balloon because you don't want any of that. And then you do that series of studies every half an hour to an hour, depends on what you feel is likely to happen. If the patient's stable, you probably don't need to inflate the balloon altogether.
Okay.
But
how much can you put in the balloon maximum then?
So
in this going until you get a cardiac output drop. Is that what the concept is?
So you've got exactly that, because the chest, the dynamics, the way the balloon is positioned. So you've got your baseline volume that caused 5% nominal drop. We think we're going to go for 5% cardiac output drop initially, and then you deflate it, and then you see what sort of volume you're going to need as you progress through the night. And it just to give you this sort of a trend that could guide your decision into where you are in sort of that curve to the bottom before the cardiac arrest might happen. So that's just we thought
where to put the balloon. Is that right? So where exactly do you place the balloon? Is it over the right atrium, or where exactly do you place it?
So that is a very good point, and I think that's the issue with the challenge. If you've got clots, you won't get a consistent pressure measurement. While if you put it behind the sternum, you are in a way affecting the whole volume. So even if the clots are on the RA, at the start of the case, you blow your balloon, there's nothing to push on the RA, you're not gonna affect it. While if you start pushing on the heart down against the RA will be more affected. So the idea is you're trying to probe the whole pericardial volume available to you by taking the volume and subtract what's available left for you for the heart to work comfortably. And I think obviously we need to see how that would translate into a human chest. So the next step would be to do it on a 3D printed chest and work out the dynamics on that and see how it translates in different scenarios. But we thought that would be the most robust method to
so I guess
avoid
people don't need to have a PA catheter anymore. So they, instead of a PA catheter swan line, they can use your device, which will be a continuous cardiac output monitor. But the added value is the balloon that they can inflate every half an hour to see how much it drops the cardiac output. Is that's the concept?
That's correct. You could potentially do that. I think the PA catheter itself is there to solve a problem of floating one, because putting the Doppler probe at the surface of the PA is relatively easy. We like to do it as surgeons. It should be easy to come out. It's the probes are now 2-3 millimeters. So it's, yeah, you're right in terms of the IP and all that is all in the balloon itself. But for once you've got all this going, right, you need to worry about other cardiac output monitoring where you can have it all built in one, and then the whole device itself, the processing device, could become your diagnostic tool, looking at the relationship and building models of probability and so on and so forth. So that's basically some sort of usability studies we've had or chatted about.
Yep. So obviously, I've never met a surgeon innovator that's bringing something to market. So where are you now, and where do you need to be? You've done patents, and have you approached companies? How does it all work?
So we have patent in place. It's going through the process of what patent needs to be, novel and inventive, and so on and so forth. There's a couple of small challenges that are very easy to overcome in terms of we are approaching relying on grants. At the moment, it's all self-investment from commercializing a cardioplegic solution. There isn't much has gone into it yet, and a couple of local grants that we've been going, but we are looking at getting in touch with industry who might find it useful, and they will be able to develop it further beyond. I'm also collaborating with some pretty good team from University of Birmingham, as well as Sheffield and Leicester, to try to go through the steps, which would be some PPI, some usability studies, and the main challenge would be obviously maintaining the patent, because it gets expensive as you go along.
So I guess there's quite a long track to go. I'm sure everybody watching this is burning to ask, when can they get their hands on it? And a patient, I suppose, what would you say, 5 years away? Or when do you think this will come to patient help?
I think you're absolutely right. It's a very long process. I am a little excited about this one, because you need to look at the regulatory side of things, and to get in a CE marking or an FDA approval, or the new regulation in changing the licensing for the UK, you have to have effectiveness, and I think that takes a while. It's difficult to prove that this is going to be effective in some way, but equally we've got the cardiac output that we could easily prove that. So I think once we've gone through the next couple of years of basic of the pre-human studies, I suspect we will be able to get it into some sort of human trial within another couple of years. So 5 years is not totally out of reach, but you need to get lucky, and it depends on the sort of amount of investment you need to get it moving very quickly. And devices like this, prizes like this, interviews and support from your peers and colleagues does help quite a bit in getting and securing funding, and B, going into market, because there is a real need for it. The point we did mention, the good figure of 1% and 0.3%, and if you look at the data, everyone would tell you from the published work, this is conservative estimates, and is likely to save a lot of lives. And equally, I find even beyond the life saving, we've got other problems that you cannot price, and these are the ones that I've got there. So there you go.
Yeah, well, it sounds like an absolutely amazing device. Congratulations on winning the EACTS prize. And just in the final last question, there's probably a surgeon out there with an idea for the next Innovator Award. How would you recommend surgeons take forward an idea? Let's say it's in someone's head, they've done nothing else about it. What would you tell them to do so they can win next year's Innovator Award?
That's very good question. And I think the first framework is if you've got an idea, you have to look at the intellectual property of it to be able to get any sort of innovation award like this, because it's always going to be whether you can exploit it commercially or not. So as effective as or good that might be this idea, you still have to have the hurdle of, can you get some intellectual property? And the next big question is, who will own that? So in most countries around the world, you can go through your employer through some sort of framework if you've got an idea developed within your workplace, and they will be able to fund the initial steps of what is required to assess the intellectual property of it. That would be the first thing to do, because without some sort of an IP, just to rely on non-disclosure agreements, things become really difficult. So a small investment towards getting the IP protected before you do much, before you publish, before you present, and that's always a bit of a difficult one to get engagement from your employer. I personally thought that, not with this device as such, because but others before, and then once you've got that, then you just have to make the case for its unmet need. I would insist that it's all about the problem as much as it is about the solution. The solution is always easy. We're always very creative. We're a bunch of problem solvers by nature. I think what makes what could tell us apart in these sort of ideas is, are we able to spot the problems that we are actually living with on a daily basis, and come up with a solution that applies not only to the patient in front of us, but actually try to have it more applicable to the mass. It's a solving one same problem that you are for one patient, but do it that applies to you and your colleagues and so on and so forth with an IP on it. So that's the kind of a nutshell of the route for that. Obviously, there are grant money for these sort of things, but again, IP is the first thing to try to secure.
Great. Well, it's been an absolutely fascinating chat with you. Congratulations once more on this amazing award, and I hope maybe people could even get in contact with you if they want to get engaged with developing this further. And so for myself at Joel Dunning at CTSNet and everyone watching, can I just say, Hazem, thank you very much indeed. Thank you.
Thank you. Thanks for having me. It's an honor.